Hey guys, we're back. Let me just move this a little closer. Okay, here we go. Hey, thanks everyone for joining. We're going to talk about unexplained. Genesis is here, so I'm going to send Dr. a request to join us, Genesis. And then you just have to accept it. So we're talking unexplained infertility, and Genesis is giving away an amazing. Here we go. Dr. Abri de Bruin. Hello, where are you?
I must just figure out how to change this camera.
Okay, so just have to swap it around.
There we go.
Here you go. We see you. So Dr. de Bruin, how are you?
I'm fine, and yourself, Leanne?
Good, thank you. I was just telling the ladies there's an amazing prize that Genesis, the team at Genesis has offered, and I can't wait to share, and we will share it at the end of the talk. And we are talking about unexplained infertility. So, firstly, if you could just give us a quick rundown about where Genesis is situated, and the three doctors that are there at Genesis.
So we're situated in Mediclinic Kloof Hospital in Pretoria, right off the Rigel ramp. We have three people working in the clinic, one fellow and two registered fertility specialists, myself, Dr. Deo, and then Dr. Potgieter, who's finishing his fellowship soon. And we are the people working at the medical people, clinicians working at Genesis Reproductive Centre.
Awesome. Okay, so we're going to get right to it. We're talking about unexplained infertility. If you could just run on how are you diagnosed with unexplained infertility?
Yeah, and I think there's an important thing that the listeners need to understand, and that is, what are all the things that we don't know? So if we do an IVF, for an example, we have a lot of information. But let's say, for instance, so the principle is we can't do IVFs on every single person that walks on the planet. So, and does every single person that walks on the planet conceive? No. And human beings are most probably the worst reproducing species in the world. I mean, if you're farming with cattle, all of that, you have a pregnancy rate with insemination of somewhere around about 90%. If you look at humans, we're looking at fertility or pregnancy rates with insemination somewhere 10-15%. So we would make very poor farmers. I think the issues that we must all understand is the following. If you come to me and you say to me, listen, doc, we've been trying now for a year, because we usually say within a year most couples would conceive. So if you haven't conceived in a year, then we need to start looking at what do we think are the reasons that we're not conceiving. So what's very interesting, the patients will come and the females will go through all the things. You must remember, I have to be a feminist as a gynecologist, but the women have examinations and ultrasounds and blood tests and x-rays and even laparoscopies. And then after all of that, we try and get to have a semen analysis. And then there's sometimes a hiccup with not being able to get hold of a semen analysis. So there's lots of things that we don't know. And that's what unexplained infertility is. At the end of the day, if we've done everything right until the end and you still don't conceive, then we can go and say, right, this is unexplained infertility. But that doesn't help us a lot. So I would rather want to throw the topic of unexplained infertility and change it to say, what are the things that we don't know at the start, and what are the things that we can find out, and what are the things that we can't find out? So what we don't know in any single patient that comes to see us is, if we do let's say, for instance, the semen analysis is normal, all the tests are normal, and we don't find any obvious reason why you're not conceiving, then depending on which fertility unit you go to, they will have different approaches on what different treatments they will do. But if we start and say, right, we're going to just monitor, if husband's got a normal semen analysis, everything else, you're young, everything looks fine, let's just see whether you ovulate and test your progesterone. Let's just do that. So we will do an ultrasound, and everyone's very excited to see that we, on ultrasound, can see the nice round black follicle. But we don't understand that that's just a follicle. We do not know whether that follicle contains an egg, because an egg is so small that you can't see it by eye. So we can only do an ultrasound, see a follicle, and then say, right, the follicle's the right size, we can trigger it, and you can try on your own for the next couple of days. But now, did that follicle contain an egg? We don't know. That's something that's unexplained. And we know that from, if we do IVF, we know that we should have about 80% hit rate on eggs related to follicles. So if we do an ultrasound on an IVF cycle and we get 10 follicles on ultrasound, we should on average get about 8 eggs. All right, so that means that 2 of the follicles are going to be empty or don't contain eggs. So we know that not all follicles contain eggs. That's the first very important thing to understand. The second important thing to understand is that we do not know what the quality of that egg is. If we do IVF, and we look under the microscope, then we look at the egg, and then we also grade the egg. Is this a mature egg? Is this an immature egg? Or is it what we call a germinal vesicle? So those are the 3 types of eggs that you get from a follicle. So now, number 1, we don't know whether there's an egg in that follicle. Number 2, we do not know what is the quality of that egg. Number 3, we do not know if the tube picks up that egg that month. We don't know that. Then we do not know if the sperm fertilizes that egg that month. And we also know that from IVF, because not all eggs that we even do an ICSI, where we inject a sperm into the egg, will fertilize the egg. So in a natural situation, we don't know whether a sperm actually fertilized that egg. And then we do not know how that embryo develops. And again, from IVF data, we know that if you have 10 eggs, or let's say we had 10 follicles and we got 8 eggs, not all 8 eggs will fertilize and form perfect embryos on day 5. We know that there's a graph that you will start with many follicles, less eggs, less will fertilize, less will divide, and less will be very good quality embryos. So that's why we're so bad at reproducing, because not every single follicle has an egg, not every egg is a good egg, not every egg develops into a perfect embryo. So if a couple sits in front of me and says, but why are we not conceiving? I always ask them, did the follicle contain an egg? We don't know. What was the quality of the egg? We don't know. Did this tube pick up the egg? We don't know. Did the sperm fertilize the egg? We don't know. How did that embryo develop? We don't know. On day 5, when that embryo arrives in the uterus via the tube, did that embryo, what was the quality of that embryo? Because we have certain criteria that we grade embryos on day 5 when we do embryo transfers. So what was the quality of that embryo? We don't know. And then, did the embryo implant? If you're not pregnant, the answer is no. And then we can delve into all the things on why did it not implant. So that becomes a whole new long topic. So just as an introduction, there's a lot of factors that we don't know. So the question is, can we find out those answers? And the answer is yes, we can. We can do an IVF. But does that mean that every single young couple that comes to see you that has not conceived after a year needs to have an IVF? The answer, in my opinion, is no. But that is the procedure that's going to give you the most answers. That is something that's going to tell you, okay, you actually make so many follicles and you actually have so many eggs, and they are actually really good quality eggs, and the sperm fertilizes them and you develop good quality embryos. Now we can start looking at other reasons. So those are the things that are unknowns, that are unexplained when we start. So that's usually the starting point when the couples are here and we talk about, okay, so why do you think I'm not conceiving? Those are all the things that we need to go through. And then you need to sit down and say, right, what are all the basic tests that we need to undergo? And I think that's also a very important thing that the listeners need to know. What are the things that we actually have to do before we say, right, we've actually done all the tests that we can do? And it's simple things like, what is the hormone profile? So the LH and the FSH hormone during the period, they need to be below a certain level. We need to find out what the lining of the uterus does. So if we see the patient during a period, why do we sound them during the period? Because we want to make sure that they do not have cysts. Because women make cysts every month. That's a normal occurrence. But if they have a cyst in the beginning of a cycle where we're going to try and get them pregnant, we're not going to do any treatment, because if we feed that cyst with any hormones, that cyst is just going to grow. So at the start of your period, we need an ultrasound that says, right, both ovaries have normal follicles and the hormone profile is normal. The next thing is we need to know whether the patient has patent tubes. So are the tubes open? Then we need to know the sperm count, or not only the sperm count. I prefer to talk about the semen analysis, because the count per se can be okay, but the rest of the sperm analysis can be horrible. So you can have a good count, but it doesn't mean that you have normal sperm. You can have actually a very poor end of the day count of normal sperm, even though you have a high count of sperm. So the sperm needs to be fine. Those hormones need to be fine. Then we must see how the follicle grows, and we usually repeat an ultrasound on day 11 or day 12, because then we know what size the follicle should be. And we also know with treatment at what speed a follicle will grow. So we know that a follicle grows with between 1 and 1.5 millimeters, or 1.5 to 2 millimeters per day. And we want that follicle to be around 18 millimeters on average before we can trigger that follicle, or before it usually will ovulate. So if we see someone on day 11 or day 12 and they have a follicle that's 16 millimeters, then we know that most probably the next day the follicle will be 18 millimeters and ready to ovulate. If we see someone on day 11 or day 12 and the follicle is still small, it's 12 millimeters or 13 millimeters, then we're going to rescan that patient 2 days later and see how that follicle is growing, because we want to know where we're going at. So together with that, the follicle that grows produces estrogen, and estrogen stimulates the lining of the uterus. So we will measure the size of the follicle, and we will measure the thickness of the lining of the uterus. And the thickness of the lining of the uterus on day of implantation, so that's now in a patient with a regular 28-day cycle, is usually on day 19. So by day 19, the lining should be more than 8 millimeters, ideally. So then if we see them on day 11, day 12, and we know what the thickness of the lining is, and we can see whether there's a proper response from the endometrium to the estrogens that's being formed from the follicle. Then we also know, all right, is the uterus and the lining growing to facilitate implantation of that embryo? And then we can trigger the follicle. But remember, now we're triggering a follicle that we don't know whether it contains an egg. But now we're working on an estimation that we know that, all right, tubes are fine, patent, the semen analysis fine, there's no real pathology that we've found. and we now know that the lining is growing, we will then test the progesterone levels on day 22 to see what those levels are, and then we know whether there's adequate progesterone levels. Progesterone levels don't necessarily mean that you ovulated. It's not always that you ovulate when your progesterone levels are high enough. So just to go, what we see a lot is people getting Clomid or Femara tablets for 6 months, and all they need to do is a progesterone level on day 22 to find out whether they ovulated. That's just wrong. We can't do that because it's completely non-scientific, and you're just actually wasting time. We need to know, is what we're doing happening? Because patients come and say, I've been on Clomid for 6 months and it hasn't worked. That doesn't mean anything. If she made a follicle on the Clomid worked. Yeah. If she had Larodex and she made a follicle, the Larodex worked. It doesn't mean that pill didn't work. It meant that she didn't conceive. But there are so many factors that play a role. And then the other things are, when we need to know that the thyroid functions are normal, we need to know basic blood tests. There are certain conditions that we need extra blood tests. And then we also need to find out, okay, so when are we going to decide to do, in a patient, everything looks fine, but it's still unexplained. They're ovulating, they're not conceiving. Yeah. What's the next step? And the next step after that is going to be that we need to do a laparoscopy, because this patient can have endometriosis that can prevent her from conceiving. This patient can have adhesions between the tube and the ovary that makes that the tube doesn't pick up the egg. This patient may have various things that play a role that we can find during a laparoscopy and that we can fix at the same time. And the other important thing is, when we do an ultrasound, is we will always do a 3D ultrasound of the uterine cavity. So that's the gold standard on how we evaluate the uterine cavity. Is it a normal single cavity? Is it a cavity with pathology? Is there a polyp? Is there a fibroid? Is there a septum? Is there a double uterus? Is there a double cavity? So all these things that, when the patients come and they can't understand why they're not conceiving, all these things are things that we can find out when we do an initial consultation. So there's a lot of things that patients can actually do before they come to us that makes the first visit a lot easier, because otherwise you see them and then you say, all right, go and do all these tests, and then you come back and then we discuss all the tests. If you have all those tests that we actually need, then it makes the first consultation a lot easier.
Yeah. I just want to say, the next question is, do you still have a chance to conceive if you have unexplained infertility? But as you're talking, I'm realizing, you know, when you hear someone saying it's unexplained infertility, you're thinking, I think that is like the worst diagnosis almost, because it's like, well, if it's unexplained, then how can you actually treat it? But the way doctors explain it is that you have to then go through all the steps and go and see why. But what is that person's chance of conceiving once they've been told, you know, it's unexplained?
I think we must just decide on what we mean with unexplained. So I would say that if you now have a patient, haven't found anything seriously wrong, now they're not conceiving on their own. We're treating them with our basic treatment protocols. Everything is going well. They're not conceiving. If you then decide, some patients, I mean, I would love to drive a Rolls Royce, but I can't afford one. So I would love to offer all my patients IVF, but not all my patients can afford IVF. So there are certain things that we're going to say, right, we can offer them an insemination or a sperm wash or whatever to increase their chances. But let's say we now have a couple where we haven't found anything wrong, and we now decide that we want to have an answer, we're going to do an IVF.
I think doctors when that happens, guys, it's someone's trying to call him, so it stops his Instagram. We'll just wait for him to come back. There's so many of you that's joined us. Just remember, after this talk, we've got 3 winners that would be able to get the 3 prizes from Genesis, but we'll wait for Dr. Abri to come back. Oh no, he's gone, but we'll just invite him back again. Let's go back. We'll just send him another invite. We'll invite him back because he wasn't done yet. Okay, just wait for him.
I'm back.
There we go.
Are you back?
You're back. We're getting
Great.
a call. That happens. Sorry.
All right. So I don't know so we now have a patient where we didn't find anything wrong, and we now decided we're doing an IVF. If we do the IVF, now we're going to get the answers on the follicles, the eggs, the quality of the eggs. We're going to find an answer on whether the sperm fertilized the egg and how the embryos developed. Now we have good quality embryos. Now we transfer those embryos into a receptive uterus. And now it's either going to stick or it's not going to stick. Then there are other problems that we can find. So we can now have patients with good quality embryos that don't conceive. Now the question becomes in which day of the cycle should we actually be transferring these embryos? Is it that we transfer the embryos on the right day, or is it that that this specific patient has a more receptive uterine lining on a later day? So we work on a 28-day cycle, which we know some women have and a lot of women don't have. And we work on 5 days post retrieval of the eggs if we do a fresh cycle when we transfer the embryos. On a frozen cycle, it'll usually be on day 19 or day 20. So we're now saying that we have good quality embryos and still you're not conceiving. That's utterly frustrating. So then the next step is to say we must now find out whether we are in the correct implantation window. So that means that we now have a test that we can do where we actually do a mock trial for an embryo transfer. And on the day that we would have transferred the embryo, we take a sample of the lining of the uterus. And we send that off to the laboratory, and they do an evaluation for us on that endometrium. And they then come back to us with an answer that says, right, this endometrium of this patient, in the way that you stimulate it in this way, seems to be receptive on the day that you did the sampling, or it seems that you're a day late, or it seems that you're a day early. So even if you have perfect embryos, it doesn't mean that the lining is always then receptive on the day that we think we should transfer it.
Yeah.
It can be that the lining of the uterus is then receptive a day later or a day earlier. So that's another test that we can do to find out, all right, when is the right time that we can transfer these embryos into the uterus. Because then if you've done that mock trial, when you do the actual transfer of the embryo, you use exactly the same medications on exactly the same days, exactly the same times, because now you have your fertile window. So now it comes back and you say, right, it says the fertile window is day X, whatever it may be, and we transfer the embryo on day X, and it doesn't implant. Now it becomes an issue of what's going on here. Now we can go back and say, right, what are the other things? And I always tell my patients that you must remember that if we look at an embryo, that embryo doesn't really talk back. So that, let's say for instance, we have 3 embryos, and we grade all 3 of those embryos equally. That is exactly the same as having 3 people auditioning for America's Got Talent, but they're not allowed to do anything. They just stand there in front of Simon, and Simon must decide on looking at them who he thinks wins the $1 million. Because we do not know what the genetic potential of that embryo is. Is that a genetically normal embryo? Is it a genetically abnormal embryo? What is going on in that embryo? So now, can we do some tests on that? Yes, we can. So we can do what we call PGT-A, where we actually send a part of the embryo away for genetic testing. And we will then get an answer back from the geneticists that tell us, listen, this is a genetically normal embryo, or this is a genetically abnormal embryo. So we can go through an IVF cycle, get the embryos up until day 5, and then on day 5, what we do is we biopsy that embryo. So we will biopsy the embryos, and we will then freeze them, because the genetic testing takes a couple of days before we get an answer. So we will then freeze those embryos, send them away for genetic analysis, and then we get a report back from the laboratory that says these are genetically normal or abnormal embryos. And then in the next cycle, we can go and make sure that we just transfer the genetically normal embryos. Yeah. So all of these things that we do increases our chance of getting a normal embryo at the right receptive time in the uterus in the right patient. But it comes at a great cost, because we're talking about endometrial dating, which is the right date. It costs a lot of money. We're talking about genetic testing on embryos. It costs a lot of money. So again, it's a question of how far is a patient willing to go. So we can say, for argument's sake, we've got unexplained infertility, but how far can I go to really say that this is unexplained? It might be that you have all these perfectly beautiful looking embryos and they're all genetically abnormal.
Yeah. So
then it's no longer unexplained, but some people will never be able to get there because it's not in their scope of being able to get all that information. So unexplained infertility actually means everything is perfect and everything is at the right and you don't conceive.
Yeah.
And that is, then you start playing a statistics game. That's saying that if you have these good quality embryos and it's being transferred on the right time, your statistics is for you that you're going to conceive. Your chance that you're going to never have a chance of having a baby is if everything is in your favor and it just never happens. And that is frustrating. Because we have another term that we talk about, recurrent implantation failure. So that means every time we have a good quality embryo and we transfer that embryo and it doesn't stick. So there's no implantation. So that all forms part of unexplained, and that's a frustrating part of fertility. If we get something wrong, it's nice because then we can say, right, this is what we think is wrong, or this is what the tests tell us is wrong, and this is what we can do to change that. But if you have a patient where everything is good, statistics tell you that they should conceive, but there are still a group of those patients that won't conceive, but they're a very small group. That's not the biggest. Your biggest group of patients are going to conceive at the end of the day if everything is normal. So your unexplained infertility, if everything is great, is actually a very small percentage of your population.
Okay. And then I think we've run out of time. Our last question: do you have any words of wisdom for the women that's currently trying to conceive?
I think important things are what can you do? I think smoking is definitely out. If you can't try and conceive if you're smoking, we must try and see how healthy we can live our lives. And I think we must also take into consideration our age, because people are delaying their fertility to a later age. And I think that we must take into consideration that the older you get, the smaller your chance of getting pregnant and the bigger your chance of an abnormal baby. So if you are planning to have kids, please do not wait until you're 38, 39, 40. Because your biggest success is in the younger population group. But I mean, the average age of patients that I see for fertility is 38 on average. So if you want to have babies earlier rather than later, because it just gets more difficult.
Perfect. Thank you, Doctor. And then we're just going to, Dr. Deo messaged me this morning to talk about the prize. So we have three winners, and the prize that Genesis is giving away is 30% discount to three winners for fertility treatments at Genesis Reproductive Centre. So our three winners is Nina Lombard. Nina Lombard, you have won, and I think you just need to give us a send us a DM or email us info@Fertility Solutions, and I'll forward your details to Genesis. And then the next one is Shavira. Shavira, you've also won. Shavira S, you've won. And then we have Punky Lala. Punky Lala, you have also won a 30% discount on fertility treatment, and that is huge. It might not sound it, but it is a huge amount on fertility treatments. You want that 30% discount. So congratulations, guys, and thank you, Genesis, for being allowed doing these talks with us, and also being so kind to help these ladies out on World Fertility Day.
Leanne, can I just tell one thing about that 30% discount? That is for the laboratory as well as the doctor's visit.
Wow.
Okay, wow. So it's not only the laboratory fee, it's also the discount is on the doctor's visits as well. The medication, wow. The medication is not affected because that's not controlled by us. That's the pharmacy, but that is the consultation fees with the doctors as well as the laboratory fees.
Wow, guys, that is huge. That is thousands.
Yeah,
you guys,
it is.
It's Nina Lombard, Shavira, and that's Punky Lala. That is an amazing prize from Genesis. Thank you, Genesis, for being so generous for this on World Fertility Day. Thanks, guys, and congratulations. Thank you very much, Doctor. Have a great day further. Pleasure.
Thanks for having us. Have a good evening. Bye.
Bye.
Bye.